thank you so much for coming and being here. I just wanted to first introduce myself and what I do. So I lead the Shared Risk and Protective Factors peer-to-peer network here in Colorado, and I work at the Colorado Department of Public Health and Environment in Policy and Communication. So as we get started, I just wanted to say a few quick things. First, I wanted to just tell you all that what we're going to be doing today. So to kick us off, I was hoping that folks could share updates about any new or exciting work that you're doing related to overdose data to action and shared risk and protective factors, or just how you see yourself see your work moving forward after the pandemic. And then we're going to hear from Madhu from the CDC, who will talk about the research she and her team have been doing and lessons learned about adverse childhood experiences with overdose. And then we're going to hear from Safe States and Health Management Associates, who are going to talk about how to move from understanding to implementation in applying the shared risk and protective factors approach to injury and violence prevention. And then the last presentation will be from the DC Department of Public Health, who are going to talk about how they've promoted equity through harm reduction. And then we'll close with just a few wrap-up items and hopefully hearing from folks what they're taking away from today. So as I mentioned earlier, I hope that you can join for all of those great sessions, but if you can only join for some and not all, that's okay. And I've also scheduled breaks between each session, but if you need to step out in like a non-break, that's totally fine, of course. And then I also just wanted to say that for those of you attending the Shared Risk and Protective Factors Conference for the rest of the week, please let me know if you have any issues. I can definitely help troubleshoot. And we're definitely going to have a lot of really great sessions and keynotes. So I hope you get a lot out of that if you're attending. And if you didn't apply to be funded to attend the conference this year and you're interested in doing so, we do these Shared Risk and Protective Factors conferences every year. And we'll do that like we did this year right after our annual meeting. So if you're interested in that, you should definitely think about applying for the peer-to-peer network to fund you next year. So I know that, especially for those of you on the Pacific Coast, it's probably like, first thing in the morning, but before we moved into our presentations, wanted to get started by giving you all an opportunity to introduce yourselves and talk about where your work is at right now. And so we were going to get into smaller breakout groups, but I think just since the time is a little tight for that, we should just open it up for the whole group. So I would love for you to talk about how you see your work moving forward post-pandemic and whether there are upstream opportunities you hope to leverage, or if that doesn't really feel like it resonates with you, just anything you'd like to share from what you've been working on as an example of working on OD2A through shared risk and protective factors. So please feel free to come off mute and just talk, or you can type your names and states into the chat box and share there, and that's totally fine. Let's see. Thanks, Heidi. Just reading your message. Heidi, if you don't mind, what other 10 a.m. session? Is that from the conference?
It's the Sexual Violence Prevention Program.
Oh, is that what you're trying to get on?
Well, that's what I was trying to get on, and it denied me, so I wasn't able to. So I logged into this one.
I see. Okay. Yeah, that's a different meeting, but let me. Do you have Danielle Tuff's information or Ray Gupta's information?
I can probably find it. I don't want to interrupt this meeting. I just want to let you know, I'll stay in this one. I just wasn't, it was concerning as to why I was not able to get in. So I don't want to keep not being able to get into the ones I wanted to get on.
Okay. Well, it looks like Colleen can chat you and try to troubleshoot. So thanks for hopping on this one though, in the meantime.
Great, thanks.
So yeah, why don't we open it up if anyone else wants to come off mute and talk about your experiences, anything you'd like to share from your work and where you're from, that would be great. Again, you can always type in the chat box.
Hello, this is Michelle. I'm with Case Western Reserve, and we're currently involved in the Cuyahoga County, Ohio OD2A project. I just wanted to mention, we're the evaluators, but one of the things that we've been looking at these past 6 months, we're starting to move forward with, is with respect to linkage to care, especially with peer support services or quick response teams, trying to identify not only barriers to treatment, but barriers to engagement. How do they engage people when they've had a non-fatal overdose or are suffering from opioid use disorder? And so those are areas where we're trying to move forward with to collect more data in terms of examining those factors. So I just wanted to highlight that.
Thanks so much, Michelle.
Hi, everybody. This is Laura Chisholm from Oregon. There are several of us attending this morning and planning to attend the later conference as well. We have been really doing a lot of planning this year. We've been lucky enough to work with Catherine and Sharon from Health Management Associates to do a series of trainings. We've wrapped that up and we've developed a theory of change for our shared risk and protective factor work. And right now we're doing some work to identify factors to prioritize, and then we're planning to do some strategic planning for implementation. And at this point, we're really sort of focusing on a lot of structural questions around how do we reorganize ourselves to get this work done most effectively. We have a lot of initiatives happening across our public health division and more broadly across our Oregon Health Authority. And so we're kind of in the process of getting ourselves organized to coordinate that work and elevate it. And in the words of, I'm trying to remember which of our Colorado colleagues mentioned it, getting evangelical all about it. So we're really excited to be able to participate today. So thanks for coordinating.
Thanks, Laura. I'm very interested to know who used that phrase. It's a I think
it might have been Lindsay, actually.
Probably. Yeah. Thanks so much for sharing that. I'm so glad that you've gotten the chance to work with HMA too, because obviously we'll get the chance to hear from them later today. Does anyone else want to share?
Hi, I'm Amber Hickman, and I am from Dove Creek, Colorado. We're a very small town. Our high school graduating class was 10 this last Thursday, so we're very, very small. I work in peer-to-peer mentoring, where I get to work with the high schoolers, and then they mentor from 4th through 8th grade on the use of drugs and alcohol and smoking and the effects of it on your body. And they try to teach them, it's called STUDS, so students tackling unhealthy decisions. And we try to teach them what the effects are as you grow. And so I'm hoping that after the pandemic, we haven't been able to get into the classroom. We've had to do a lot of Zoom. And so I think getting back into the classroom with the kids will be a lot more effective. We've had quite a bit of vaping and smoking and drug use with being such a small town and being bored, I think, a lot. And so we're hoping to get back into the classroom to show them and be more effective in that.
Thank you for sharing that. Hillary or Stephanie or anyone else, do you want to talk a little bit about what you shared in the chat box?
Hi, I'm Stephanie Olson. I'm the Sexual Violence Prevention and Education Program Manager in Kansas, and we've been trying to use a shared risk and protective factor with all of our injury and violence prevention programs, trying to really reach more upstream to collaborate together, but also align some of our work so that we're not duplicating efforts and really working a little bit more efficiently.
Great. And I should say, actually, on that note, if you have been following our learning opportunities that we've been doing, you probably already know this, but just for everyone on the call, I'll send out a link in a little bit to them. But we have some past webinars that we recorded about shared funding opportunities. And also, if you're attending the conference, there'll be some sessions on that as well, which is just, I know, just really helpful to hear about when you're thinking about how to de-silo some of these programs and work together on how we can leverage funding for that. So just wanted to say a quick plug for those sessions.
I would plug all of those recordings. I think the ones about data were just very helpful as we were starting to think about how we could work at that shared risk and protective factor level and programming. So yeah, that's been a really great resource.
I'm so glad to hear that. Yeah, I will definitely send out, actually, I'll send it out into the chat box right now, a link to those past recordings so that if anyone wants to check them out, they can. I think we have time for one or two more folks to share if anyone wants to.
This is Joanne in New Hampshire, and I put into the chat box the link to our state violence and injury prevention plan, which was completely based on risk and protective factors and how they overlap, and trying to look upstream and then sort it out by different types of injury. And it includes rape prevention, suicide prevention, falls prevention, teen driver safety, and a whole bunch of other things. So it's a pretty comprehensive report. I can't take credit for it because it was a complete team effort between all my stakeholders, but I think we all put together something quite useful.
That sounds great. I can't wait to check that out. Thanks, Joanne. Does anyone else want to share before we move forward? Okay, well, I really appreciate everyone who has shared coming off mute and typing into the chat box. It's great to hear the kind of work that everyone's doing. And if you haven't shared and just want to introduce yourself and where you're from and even your role into the chat box, if you don't want to share an update, that would be great too. We're also going to have an opportunity at the end of the meeting today to just share a little bit about like action items or inspiration that you're taking away from today. So, and if you hear from someone that is either part of the network or presenting that you're interested in learning more about their projects, please feel free to either to just reach out to me and I'm happy to connect you. I think that's a huge part about the purpose of this network. And so I'd be really happy to do that. So thank you. And next, we're going to hear from Madhu from the CDC. Madhu, you should have access still to share your screen. I'm going to stop sharing so that you can.
Can you hear me okay still?
Yeah, perfect.
Okay, excellent. Let me share my screen. Okay, someone flag me down if anything looks funky on my screen. But thank you so much, Kate, for giving me the opportunity to present to you all today. To everyone, good morning, good afternoon, wherever you are. My name is Madhu Govindu. I'm an ORS fellow and a prevention science officer for OD2A here at the Division of Overdose Prevention at CDC. For those of you who are familiar with April Wisdom, I work very closely with her on a slew of projects in overdose prevention and also on ACEs. And I'll be presenting on one of those today. So today I'll be walking you through how jurisdictions in the CDC's Overdose Data to Action, or OD2A, cooperative agreement, are conducting prevention work at the intersection of adverse childhood experiences, substance use, and overdose. And this is a project that we've been working on for the last several months and we're currently in internal CDC review on our manuscript. So I'll be presenting some of our findings from that. So to kind of set the groundwork for today's presentation, I'll walk you quickly through the relationship between adverse childhood experiences, shared risk and protective factors, and substance use. And then I'll discuss how and what CDC is doing to prevent ACEs. And that'll kind of set the stage as I move into our manuscript team's work in understanding ACEs prevention within OD2A. And then we'll conclude with a short question and answer period to address any questions you all have. I'll do my best to address those questions, but if not, I can definitely take them down and get back to you all. Or you're also welcome to email me if there's any questions. So to begin with, what are ACEs? What are shared risk and protective factors, and how are they related to substance use? So as you all know, adverse childhood experiences, or ACEs, are preventable, potentially traumatic events that occur in childhood or among children 17 years of age or younger. Examples of ACEs include multiple types of abuse, such as physical abuse, emotional abuse, sexual abuse, types of neglect, or experiencing a violent event, or having a family member attempt or die by suicide. These aspects of a child's environment can undermine their sense of safety, stability, and bonding, potentially contributing to significant effects in adolescence and adulthood, such as mental health issues, chronic health issues, and substance use. So Bertha's data published in 2018 indicate that as many as 61% of US adults have experienced at least one form of ACEs in their lifetime, with about 1 in 6 adults reporting having experienced 4 or more ACEs. And those most at risk for experiencing such a high number of ACEs really include females, individuals in the LGBTQ+ community, and also most racial and ethnic minority groups. Experiencing these ACEs and their associated traumas can cause lasting impacts that occur well into adolescence or adulthood. So some of the associated negative outcomes can include depression, PTSD, various infections or chronic disease outcomes, increased risky behaviors such as the drug or alcohol abuse, and less opportunities for educational or career advancement in adulthood. So a variety of factors have been found to moderate the risks or the traumas associated with ACEs, which, as you all know, are collectively called the shared risk and protective factors. These risk factors increase the likelihood of experiencing an ACE, while the protective factors prevent or mitigate the traumatic effects that can occur from an ACE, kind of facilitating those safe, stable, nurturing relationships and environments. Here I've included a short list of risk and protective factors that occur at the individual level, at the family level, and the community level. And as you all know as well, this list is definitely not exhaustive by any means. An additional SRPF can be found at the link provided here. So some examples of individual level risk factors that can lead to ACEs or lead to substance use include delinquent behavior among children, or their inability to discuss their needs or emotions. But some individual level protective factors can include them being able to develop those positive friendships, being able to engage in positive peer networks, having access to positive mentors, things like that. And then at the community level, we see risk factors such as easy access to drugs and alcohol, instability within the community, and just limited opportunities overall for these children to thrive. But then these protective factors at that community level can include facilitating access to high quality childcare, schooling, and family-friendly work policies. So the stratified nature of the shared risk and protective factors, kind of how I presented it at the individual, family, and community level, becomes important when we look at the social ecological model, or the SEM. The SEM is the key framework that's utilized by the CDC for prevention work. So the SEM highlights several facets of prevention work, such as how each level influences subsequent levels of the model. The SEM also kind of indicates how or highlights how approaching interventions at multiple levels of the SEM can increase the sustainability of prevention efforts, and how those efforts can improve the likelihood of more of those population level impacts. So here in this figure right here, individual level strategies can include anything, any activities that target the attitudes, beliefs, or behaviors of a single person. And then moving along in the next level, relationship level strategies are looking at any programs that enhance the social or familial networks, such as peer programs, parenting programs, or programs that promote healthy relationships. Community level interventions are usually tied to organizations or physical settings, such as schools, hospitals, various public health or public safety agencies, or even workplaces. So these strategies include creating safe settings for individuals and improving those community level determinants of health. Lastly, the societal level of the SEM examines broad factors that can influence all the lower levels of the SEM, so the community level, the relationship level, and the individual level. So these mainly include things like changes to policy at various levels of government. So to further illustrate the importance of examining ACEs and substance use work through an SEM lens, I'd like to highlight this specific image. So I can't see everyone on the screen right now, but maybe by unmuting, how many of you are familiar with a pair of ACEs, or how many of you have seen this figure, encountered this figure in any of your work? Let me see if you can try to raise your hand. Okay, I see a couple of raised hands. Okay, that's great, that's great. Okay, that's awesome. So for those that may not have encountered this image, I'm so sorry, one second. I'm having some technical difficulties here. There we go. So to any of you who may not have encountered this image before, this image really illustrates the close interplay between not just the individual or those relationship level factors that can increase the risk of ACEs, but also the community and societal level factors that could increase the likelihood of experiencing an ACE. So here, the branches and leaves are meant to represent those individual or family level or the relationship level factors, such as abuse from caregivers, experiencing neglect from caregivers, mental health conditions among caregivers or parental figures, or even parental substance use disorders or substance use in general. The roots here are meant to represent those community level systemic factors that contribute to ACEs. So things like poverty, lack of access to economic or social support, or even community-based violence. So this figure really illustrates that by only addressing the factors in the branches, so those individual level or those relationship level factors, and by neglecting the societal and community level factors that are at the root of this tree, we can't really hope to effectively mitigate and prevent ACEs that stem from these systemic issues. So in order to collectively address the issue of ACEs, we need interventions that target all those levels of the social ecology. So the individual, relationship, community, and societal, but especially looking at the community and societal levels, because those have the potential for the broadest impact and reach. So how are these three things related? ACEs, substance use, risk and protective factors. So substance use plays a significant role in both ACEs and shared risk and protective factors work. As we discussed earlier, access to illicit substances is a risk factor for ACEs. Substance use among parents is also a potential source of ACE in childhoods or in households, excuse me. Furthermore, experiencing ACEs increases the risk of substance use and trauma in adulthood, highlighting that intergenerational cycle of ACEs and substance use, which we'll discuss a little bit more further along in the presentation. So these three concepts are intricately linked and are being increasingly examined together through a prevention lens. So to further highlight this, data published by SAMHSA in 2017 indicates that close to almost 9 million children live in a household where at least one parent has had in a past year substance use or a substance use disorder, which is about 12% of children under the age of 17. So this indicates that there's a good subsection of children who are at risk of experiencing ACEs and their associated impacts. And this is another graph that further illustrates the relationship between substance use and ACEs. So here we see a dose-dependent outcome on ACEs by drug use. So overall, we see that individuals who've experienced a greater number of ACEs are at greater odds for using or injecting drugs. So you can see here, those that have experienced four or more ACEs are across the spectrum more likely to have alcohol use disorder, use illicit drugs, or inject drugs. So these factors all closely tie into the importance of addressing ACEs within a substance use prevention lens, and that's what we're going to be discussing today. So again, examining this intersection of ACEs and substance use prevention becomes important as we work to mitigate these adverse health outcomes that overlap the two issues. So research has indicated that ACEs prevention work could lead to significant reductions in health conditions such as depression and heart disease. And furthermore, prevention programs allow us to break the intergenerational cycle of ACEs and substance use. This breaking of the cycle, so to speak, also includes examination of neonatal abstinence syndrome related work. So as shown by that pair of ACEs visual, ACEs don't have just individual level factors, but they also have community level and societal level factors that can cause these multi-generational cycles. So including NOS prevention or NOS considerations in prevention work could offer a unique opportunity for interventions for multiple generations. So what is happening at CDC? What is CDC doing to address ACEs? So CDC developed 5 technical packages related to violence prevention, which I'm sure many of you are familiar with based on the work that you're doing. And these technical packages address areas of child abuse and neglect, intimate partner violence, sexual violence, suicide, and youth violence. So these technical packages are really designed to help communities and states prioritize their prevention activities based on the best available evidence. So using these 3 technical packages, CDC collated all the best strategies to prevent ACEs into the ACEs prevention resource, which I think some of you also are familiar with. This resource really showcases the strategies that have the best available evidence to prevent ACEs. So there's 6 main strategies that are highlighted in this resource. And the resource really stresses that these strategies can be combined in a multifactorial approach to maximize the impact of these strategies, and also create those safe, stable, nurturing relationships and environments that can decrease the likelihood of experiencing ACEs or mitigate those adverse effects of ACEs. So these 6 strategies include strengthening economic supports for families, promoting positive social norms against violence, connecting youth to caring adults and mentors, ensuring a strong start for children, teaching skills, and intervening to lessen harm. And I'll do a deep dive into each strategy to provide some additional context. So strengthening a family's economic supports can include things like child tax credits, implementing family-friendly work policies, or just paying caregivers a living wage. So these strategies can lead to decreased parental stress or other adverse mental health issues that can stem from a lack of affordable childcare for children or potential loss of income. So this can allow them to better meet, so providing these economic supports can allow parents to better meet their children's needs. So this reduction in that parenting stress may lead to better parenting outcomes, better parenting and related outcomes, also potentially decreasing ACEs exposures, and also providing long-term benefits for the children. Changing beliefs and expectations around violence is another key component of ACEs prevention. So some ways to promote these positive social norms include educational campaigns that are aimed at changing how people think about ACEs. And other approaches can include mobilizing bystanders, especially men and boys, to speak up and stand up against violence, which has really shown to decrease sexual violence. So overall, focusing on changing group level beliefs, group level expectations, and overall social norms around violence can help focus on a more community-based approach to creating those safe, stable, nurturing relationships and environments for children. Ensuring that children are supported in a positive environment from an early age is another strategy for preventing ACEs. So providing children with high quality childcare and enrichment programs, especially with caregivers or familial involvement, allow for children to develop those physical, emotional, social, behavioral, or intellectual capacities that their parents may struggle to provide for a multitude of different reasons. This in turn could improve the likelihood of more positive educational or professional outcomes, and also creating, again, those safe, stable, nurturing environments for these children. Several programs are aimed at teaching skills. These include social emotional learning, so things like how to handle stress, how to resolve conflicts, how to manage feelings or emotions. And so these types of programs have been shown to improve children's mental health outcomes, their educational performance, and then overall showing a reduction in drug use and other risky behavior among adolescents. And to go along with teaching skills, not just for children, but skills-based programs can also include relationship building at the family level or focusing on parental skills programs. So these programs have been shown to, again, improve the parental stress, encourage positive parenting techniques, decreasing child abuse and neglect, protecting children from various forms of violence, and overall decreasing behavioral problems and drug use among children. Mentoring and after-school programs offer an opportunity for students to build relationships with positive mentors and networks, and this overall leads to an improvement in educational outcomes. So for students, especially those with a difficult home environment, these programs can mitigate the impacts of family stressors and conflicts by providing a safe space with those positive relationships. And last but not least, direct intervention to reduce the harmful effects of ACEs involves enhancing primary care through trauma-informed and other victim-centered approaches, providing treatment for behavioral or substance use issues, and implementing treatments that mitigate the effects of ACEs. So providing these interventions may, like I mentioned, mitigate the effects of ACEs, but also prevent future ACEs, and then also, like we mentioned previously, break that intergenerational cycle of ACEs and substance use. So now that we've kind of set the stage, let's now delve into our manuscript, some of our findings, and some of our conclusions and implications for practice. So just to provide some quick context for anyone on the call that may not already know, OD2A is a 4-year, $1.2 billion cooperative agreement that funds 66 jurisdictions across the country to conduct overdose surveillance and prevention work. So the surveillance strategies include things like tracking non-fatal overdoses treated in the ED, tracking fatal overdoses with detailed toxicology and circumstances data, and innovative surveillance activities. Prevention strategies include those that examine and educate prescribers on safe prescribing practices, enhance relationships between state and local public health agencies, provide linkages to care for individuals with SUD, encourage partnerships with public safety entities for its multi-sectoral approach to overdose prevention, and delivery of harm reduction services to educate individuals on safe choices. So given the close relationship between ACEs and substance use, for our manuscript, for our paper, we really wanted to examine ACEs in the context of overdose prevention. So our primary purposes of the paper were, one, to identify and categorize ACEs-related activities that are being conducted by OD2A jurisdictions. And these were categorized, using the ACEs ACEs prevention resource, and also the social ecological model that I covered. Our second purpose is to identify gaps and opportunities for enhancing primary prevention of ACEs through overdose prevention activities. So in order to understand ACEs and OD2A, as we're calling it, our team first began by conducting a systematic document review and data extraction from OD2A jurisdictions deliverables. So the year 1 grant applications, the year 1 APRs, and the year 2 work plans. Extractions included things like activity descriptions, the status of the activity, so is it ongoing, is it completed, was it discontinued, populations of focus, implementing sectors for each activity. So, for instance, if there's a activity that's related to school-based programming, who is doing the implementation? Is it occurring in the educational sector? Is it occurring through the public safety sector? Who's doing the implementing of these activities? What corresponding OD2A strategy is this activity in? And then whether the activity was related to neonatal abstinence syndrome or not. Data extractions were followed by data cleaning, where any activities that were discontinued or too far upstream to code using the ACEs prevention strategies or the SEM were removed from our analysis. Following this, we coded each activity based on the ACEs prevention strategies and the SEM. So through our work, our initial findings indicated that of the 66 jurisdictions currently funded through OD2A, 34 are currently conducting some form of ACEs-related activities in their OD2A programming. These jurisdictions combined are conducting 84 total ACEs-related activities, and 39 of those are specifically related to NA. And here is kind of a quick visual of our analysis. So we can see the various jurisdictions conducting ACEs work here. So we have 7 counties, 1 city, 1 territory, and 25 states that we identified in our specific analysis. Each jurisdiction is implementing anywhere between 1 to 8 ACEs-related activities, and Puerto Rico, Maricopa County, and Clark County are implementing the highest number of ACEs-related activities. So in our analysis, 7 of the 10 OD2A strategies are represented in our findings. So most of these activities in our analysis fall under strategy 5. So as you can see here, of our 84 activities, 23% are comprised of strategy 5 related work. So that integration of state and local efforts. And then a close second is strategy 6, so linkages to care. So 20% of our activities in our analysis fall under linkages to care. And then here you can see, strategy 3 is represented, which is those innovative surveillance activities. Strategy 7, which is provider and health system support. Strategy 8, which is that public health, public safety partnership. Strategy 9, which is empowering individuals to make safer choices. And strategy 10, those innovative prevention approaches. So all of these strategies, these 7 strategies, are represented in our analysis. So like I mentioned in the methods slide, we coded our activities based on the ACEs prevention strategies from the prevention resource and the social ecological model. So the visual here highlights the activities that were not focused, and there were 45 of those, and of those, the vast majority, as you can see here, really fall under the promote social norms prevention strategy and the intervene to lessen harm prevention strategy. And they fall at the community level of the social ecological model. No activities were noted that ensured, there were really no activities under ensuring a strong start in this specific category. So this highlights a gap and potential opportunity to develop future programming. So examples of activities that fall at those intersections of promote and community and intervene and community include, so for promote, it includes educating large organizations about the prevalence and impact of ACEs, and training first responders about the principles of trauma-informed care, trauma-informed approaches, ACEs, and also building resiliency. At the intervening to lessen harms and community level, that intersection really showed us activities that are focusing on providing linkages to care through first responders for youth that have experienced trauma, and also providing substance use screening, linkages to care, and care coordinations through family support specialists, specifically in pediatric medical homes. Our next category was those activities that are specifically focused on NOS, so infants suffering from neonatal abstinence syndrome. Of these 39 activities, intervene to lessen harms at the community level of the SEM was our most populated category. Promote was a close second, but unfortunately, we didn't really see any activities that were focused on teaching skills or strengthening economic support or connecting youth with caring or positive mentors in this specific category. So again, this highlights another opportunity for intervention development and implementation. An example of activities that are occurring at this intersection, specifically for with that NOS focus, are things like revising NICU protocols for infants with NOS, with SME input, or implementing a community-level task force to improve outcomes for pregnant women with SUD, their newborns, and their partners. So this is a figure from a manuscript that highlights overall kind of what I've talked about in the last 4 slides. So this visual really looks at our strategies that we found in our analysis, stratified by the SCM and the ACEs prevention strategy. So as you all can see here, the community level is very well represented here. But there's very few activities that are occurring at the societal level. And like we mentioned previously with the ACEs, the pair of ACEs figure, with that tree and the branches and the roots, the community level and the societal level factors really, or activities really have the potential for the broadest impact. So again, this is highlighting the opportunity for developing or implementing societal level activities for both ACEs and substance use related work to have that broad, far-reaching impact at the population level. So what are our conclusions? What are our implications for public health practice? So most of the activities examined in our paper are at the community level of the SCM, like I showed in the last slide, and they're focused on either promoting social norms or intervening harms or intervening to lessen harms associated with ACEs and trauma. So these levels at the community level, these strategies at the community level have the potential for the broadest impact for both ACEs and overdose prevention. Our paper is also one of the first to examine cross-cutting strategies at the intersection of ACEs and substance use at the federal level. So due to the well-established link between substance use and potential adverse impacts for youth that are exposed to it, we believe that substantial continued federal assistance, specifically for primary prevention of ACEs, are necessary to support both ACEs and overdose prevention. And this need to support this work at this intersection of these two fields is further highlighted by recent data published from the CDC that examined the effect of COVID-19 on substance use, overdoses, and child abuse and neglect. So we've seen through COVID that overdoses, substance use, child abuse, and neglect have all increased as a result of this pandemic, and also the associated mitigation efforts, so things like social distancing, closures of support facilities, et cetera. So this, again, underscores that need for cross-cutting work at the intersection of ACEs and substance use. Our study also examined the NOS activities, NOS-related activities in the context of ACEs prevention. So some NOS-related activities, such as screening and treatment for mothers with substance use disorder, fall under that secondary or tertiary prevention of substance use disorder, but they also concurrently work to intervene for the youth at highest risk for experiencing ACEs, so the children born to mothers with SUD. Furthermore, we discovered a unique opportunity for intervention with mothers with SUD through parenting programs or home visiting programs. So these programs not only benefit the parents that are at risk for substance use or have substance use through parental skills trainings, but they also benefit the children that are born with NOS and are at risk for experiencing ACEs through facilitating parent-child interactions, parent-child attachment, and identifying ACEs-related problems before adverse outcomes such as trauma can occur within the family. Of the jurisdictions that we examined in our study, there were 6 that were also conducting school-based prevention programming aimed at preventing substance use initiation among school-aged children. So while the programming has a substance use and an overdose prevention focus, this strategy can also be looked at as a primary prevention strategy for ACEs, given that it's attempting to prevent SUDs that occur later in life, which could then become an ACE, parental SUD. So this again addresses that intergenerational and multi-generational nature of ACEs. So in this figure here, we see that parental SUD leading to a child potentially experiencing an ACE, that ACE potentially leading to associated traumas or adverse impacts, and that potentially causing that child to later develop SUD in adulthood, again, leading to that cycle again, that intergenerational cycle. So while primary prevention of ACEs is currently not allowed in the OD2A cooperative agreement, framing activities as breaking this intergenerational cycle may allow for greater implementation of this type of cross-cutting work. So upstream programming could, like I could discuss previously, this upstream level programming could be used to break that intergenerational cycle. And some examples of that programming include South Carolina's Strengthening Families program, their Good Behavior Game, and their Botvan life skills training. So all of these programs have the potential to break that cycle by improving children's protective factors, increasing knowledge and skills of caregivers, and also mitigating the impacts of ACEs in high overdose burden areas. And then other upstream activities are occurring right here in Colorado. So through the Shared Risk and Protective Factors Network, Colorado is really working to increase the capacity of jurisdictions to incorporate these shared risk and protective factors into ACEs and SUD work. But unfortunately, due to the nature of our specific analysis, this upstream programming wasn't included, but it's definitely highlighted as a significant opportunity to, again, break that intergenerational cycle. And as I discussed previously, there's a significant gap in interventions and activities at the societal level of the SEM, and this level really has the potential for the broadest impact and population level change for ACEs and substance use prevention. Currently, most of the evidence-based programs are delineated as either ACEs or SUD, but they have the potential to mirror each other. So for example, peer recovery programs in substance use disorder prevention really mirrors the ACEs strategy focused on connecting youth to positive role models. So utilizing these types of strategies to do that cross-cutting work across ACEs and substance use and leveraging braided funding that addresses those fields is definitely an important consideration to advancing work at this intersection. So I've taken up a lot of your time talking, but before I conclude, I'd definitely like to acknowledge the lead author on this manuscript, April Wisdom, and the contributing authors that you see here represent our prevention, surveillance, and science arms in the Division of Overdose Prevention and within the National Center for Injury Prevention and Control. So I'd like to thank you all very, very much for taking the time to attend the session and listening along. And just a quick disclaimer that the findings and conclusions in this presentation are those of the authors and do not necessarily represent the official position of the Centers for Disease Control and Prevention. So with that, I'd like to take a pause, open it up for questions or any comments, feedback, whatever you all might have. And I'm going to stop sharing my screen so I can see folks and also see the chat.
Thank you so much, Madhu. What questions or comments do people have? I see already, obviously, Kat and Laura talking about how fantastic this was and looking forward to this paper. So am I.
So I have a question for Madhu. Thank you so much. This is Laura in Oregon. I'm wondering, I'm the PI for our Data to Action grant in the state, and this is just like my brain's kind of exploding right now. So I'm just thinking about all the opportunities. And one of the things I'm wondering is, are there plans from, I guess I would like to suggest if there aren't, from CDC to create a community of practice around this within the OD2A milieu, just because I think it would be really, really helpful to be able to chat with folks from other states who have kind of really started putting the pieces together with this work. So just a suggestion, and I'm seeing Anne Milliken also nodding as well. So apparently I don't know if we have a quorum, but.
Yeah, absolutely.
Yeah, absolutely.
I'm so sorry.
I'm so sorry. Sorry, I'm on 2 different audio devices just in case I lost access to Zoom. Apologies. Can you still hear me? Okay. Yeah, Laura, that's a great suggestion. I don't personally know of any discussions happening, but that doesn't mean that they aren't happening. That just means that I haven't been exposed yet. But that's definitely something that I can bring up with our branch leadership and also our OD2A leadership. If that's a consideration they can make moving forward, because yeah, it is a great idea. And I know that intersection of ACEs and SUD and work at that intersection is definitely something that's kind of blowing up, so to speak. And so, yeah, so I can definitely bring that to our leadership and see if that's something that we can implement.
Yeah, thanks. I just saw Colleen Kapsamalis Doyle had just mentioned maybe this is something that their network could support. I've been thinking too about funding this work, and I think one of the things that's really exciting about your presentation, just thinking about how there's so much resource right now, at least in our state. We just passed a big ballot measure related to what we're doing with our marijuana tax, our cannabis tax money. There's so much money coming out from SAMHSA related to substance abuse prevention and particularly COVID emergency funds. And, so I think there's so many really interesting ways we could think about braiding funding to really, really support communities in doing this work, on a really big scale. So my head is just going like this.
Yeah, and that's a very good point. And like I mentioned in the presentation, there's definitely several strategies that mirror that are in the SUD prevention space that also mirror ACEs strategies. So it's kind of like killing 2 birds with 1 stone in terms of preventing not just SUD but also ACEs. And again, not to keep saying this phrase, but breaking that intergenerational cycle for both. So yeah, no, there's definitely opportunities out there to braid that work and leverage that funding. So yeah, that's great. And also, before I kind of run out of time, I definitely also want to acknowledge, I saw that Sarah Bacon was on the call. So I definitely want to acknowledge her because some of that background information from my presentation was borrowed from her work on ACEs. So I definitely want to acknowledge her contributions to my presentation as well. So thank you, Sarah. Are there any other questions, comments? I can also drop my email into the chat. So if there's any other questions or anything that pop up, feel free to contact me.
We have a couple minutes left. So anyone have any other questions or comments for Madhu? Okay. Well, like she said, her email's in the chat. Oh, actually, I think that you accidentally sent it to me, so I'm just going to copy and paste it and send it to everyone. But also, if you lose that, feel free to connect with me and I can definitely connect you with Madhu. So thank you so much. That was a great presentation, and I'm looking forward to seeing more about it, and we'll send out the slides from today's presentation to folks after, so you can look out for that. But thank you so much, and feel free to stick around for the rest of today or not. Whatever you want to do is totally fine. Okay, so now we're actually going to head into a break before we hear from Safe States and HMA. We'll do about a 7-minute break and reconvene at 11:05 Mountain Time, so 1:05 for many of you who are on the East Coast. I'll be in and out during the break, so feel free to chat with me if you have any issues. So I'll see you all in about 7 minutes.
Like Kate said, I'm Catherine Guerrero. I'm with HMA, and I'm here with my colleagues, Shannon Breitzman, and our colleagues from Safe States. And we'll talk to you a little bit about sort of some of the work that we've been doing with different states, what we've learned about kind of preparing, getting ready to implement shared risk and protective factor programming, and some of the things that it's important to think about. And then we want to do some, maybe some thought work around with you all around how to apply this to OD2A. So I'm going to introduce myself really briefly, and then I'll let my colleagues introduce themselves, and then we'll kind of get started. But like I said, I'm Catherine Guerrero. I'm with Health Management Associates. I'm a principal based in Denver, and I've been with Health Management for HMA for about 2 years. Before that, I worked in community-based nonprofits and health departments. I started out at the Colorado Department of Health and Environment a long time ago, working with Shannon Breitzman, Lindsay Myers, and some other folks at the very beginning of the shared risk and protective factor work. I was RPE director there. And then worked in North Carolina, both at the health department and then at the State Domestic Violence Coalition, where we did a lot of shared risk and protective factor work, both in collaboration with other state level partners, and then through our Delta grant, right? So we did a lot of work, some of the work similar to what we just heard about, to do intimate partner violence prevention. So that's me. Shannon, do you want to introduce yourself, and then we can turn it over to Carly and Eva?
Sure. Hi, everybody. Shannon Breitzman, also principal in our HMA Denver office. I've been with HMA for about 5 years, doing public health and behavioral health work here. Before joining HMA, I was at the Colorado Department of Public Health and Environment, where I worked in our violence and injury prevention mental health promotion branch. With the lovely Colleen Capsamalis Doyle and others. And I'm very excited to be here with you all today. Thanks for having me.
Hi there, my name is Carly Roberts. I'm a program coordinator with Safe States. And I'll pass it over to my colleague, Eva.
Hey everybody, Eva Bland. I'm a program coordinator at Safe States. Excited to talk with you all today. My background is not as wide as Catherine and Shannon because they are rock stars in the field. Prior to Safe States, I was at UNC IFRIC for a while. So I've been doing this kind of work for a little while, and I'm excited to talk to y'all today.
Excellent. So we, like I said, talk a little bit about the current state of work as we understand it. Learning a lot. We've learned a lot with Safe States about readiness and about how to move from whatever place you are ready, however ready you are, to the next steps in terms of implementation. We're thinking our goal is, I guess, by the end of this conversation in an hour and a half from now, that you all would have a good sense of what we've learned, what the types of readiness are, what's important to consider as you're preparing or as you're engaging in work to apply a shared risk and protective factor approach. Thinking about the lessons that we've learned as we've worked with some states that are engaging in this, and some of them are on the phone. And so those of you that are on the phone, feel free to chime in at any point that you think you could be helpful or we get something wrong. And then, like I said, we want to give you a chance to talk with each other. We've got some facilitated questions that we want to walk through with groups. We're going to set up some groups and let you self-identify kind of where you think you are in this sort of spectrum of readiness, and then have some conversations about OD2A specifically and what you heard in the last presentation and what might be important going forward in terms of resources that the peer-to-peer network could provide, or CDC could provide, or you all could provide each other. And then we'll talk a little bit about some resources, both generated by Safe States and then some other opportunities to get support through the work. So we'd like to start, you all maybe know each other, but it's always helpful for us if you wouldn't mind dropping in the chat your name, your role, your state. Some of you have already done this. So if you've already done that, maybe what's one thing you'd like to get out of today, so that as we're kind of going through this process, we can make sure that we can meet as many of your needs as possible. And Carly and Eva and Shannon, I'll let you sort of kind of keep an eye on the chat as I go through the first set of slides, but and then we'll just trade off depending on who's talking. All right, so next I am going to turn it over to Carly and Eva to kind of just give us an introduction and talk a little bit about readiness as we've begun to define it through our assessments of states and kind of continued work.
Sure, thanks. So just to give you guys kind of an overview of why we're here. Safe States has been working with HMA, and we've done a few different assessments with about 8 states now, kind of assessing and just looking and seeing where they are with their shared risk and protective factor readiness. So specifically, we're kind of looking at theoretical readiness of the states and operational readiness to implement such work. So we're looking at attitudes and beliefs from internal staff and external partners, understanding of shared risk and protective factors, frameworks and organizational culture, and the available resources and barriers there are to kind of implement this type of work at a state level, and specifically with state health departments, IDP programs, and partners. And through these different assessments, we've come away with a few different lessons, and we've learned a few things from the states. So we wanted to share a little bit of those lessons that we've learned from the states and just some key takeaways from that. Yes, perfect. Thank you. So start off just a few of the key pieces. First being, and one of the things that we've heard across states around implementing shared risk and protective factor work is that time and money are scarce. I mean, this is obviously one of the biggest barriers in this work, and we hear it from every state just about that time and money are scarce, and that often groups are siloed based on funding streams. And along with that kind of feedback, we also hear that this is the way it's always been done. I know it's important, shared risk and protective factor approaches are important, but we don't know how to break these siloed funding streams that we find ourselves in, and we don't have the time to figure that out. So some of the things that we've learned from other states that have worked for other states and strategies that have been suggested that we've seen working is just rethinking the way you think about this work. And so reframing limited capacities as a shift in priorities is one example that has worked. So pooling resources together so that you can use multiple funding streams to accomplish this kind of work is definitely one strategy that we've seen. One thing to keep in mind, what you see and how you see your program, your IVP program and your work is not necessarily what your partners see. So even though you're in this siloed culture, a lot of times we see through these assessments and the interviews with partners is that they don't see that siloed culture. They don't see that your funding is siloed in that way. So keeping that in mind is always important. Putting focus on the bigger picture. Again, we're also very tied to our topic areas and the specific work that we're doing day to day. But when we're thinking about shared risk and protective factors, it forces us kind of to think upstream and to think bigger. So putting a focus on this bigger picture definitely helps in developing this kind of work, and taking yourself out of your everyday work, which can be difficult. Communication and thinking about developing a sharing culture or fostering a sharing culture has also been helpful to this type of work. You know, when in doubt, overshare. One of the things we've heard back from states that are really well developed in this work is that they have open communication with their partners. They're aware of what their partners are doing. One of the things that often we've seen in some states is that there can be an overlap of work happening. There's people working in similar areas that aren't even aware that they're working in similar areas, or working on similar coalitions that aren't even aware they're in similar coalitions. So developing a sharing culture and fostering a sharing culture with your partners and internally within your IBP program has definitely been a strategy that's worked. Another thing we've learned from states is that people typically understand the why, they just don't understand the how when it comes to shared risk and protective factors. So states really want to see applicable examples when it comes to shared risk and protective factor approach to make the concept less abstract. And partners really need to see actionable steps and know what's next in shared risk and protective factors. So there's some strategies that have worked for other states that we've seen. It's just reviewing existing materials, knowing what kind of work is already out there. I know CDC presented on their technical packages that they have, and they have the Connecting the Dots document, which is a wonderful piece of work to share with partners. Safe States, we have the Connections Lab. There's lots of trainings out there. So knowing what types of materials around shared risk and protective factor approaches are out there is definitely a great way to help expand the how. Connecting your own dots. This is something we've seen with some states is just knowing what your actual work is and how it relates to shared risk and protective factors and shared risk and protective factor approach. So having applicable examples and making the concepts less abstract and tying your work to how this approach is laid out. One way to do that, and we'll talk a little bit more about it later, is Safe State Connections Lab. We have a conceptual layout for how you can think about shared risk and protective factor approaches, and approaching that with your work in mind can definitely make it a little less abstract and hopefully a little bit more real. So connecting your own dots to this kind of work. Another suggestion is just starting small. We've seen some states really succeed in developing pilot work around shared risk and protective factor approaches, or even using current funding opportunities to develop small shared risk and protective factor activities with the intent to scale up as new funding may come available. So starting small is definitely a good way to get into this type of work and to build up. I'm going to have you, next slide, please. Oh, thank you. So another thing that we've heard from states is that language is confusing, and that is across all states. And it's not surprising. You know, one of the things that I hear a lot is, okay, is shared risk and protective factor approaches the same thing as root causes? Is it the same thing as resiliency? How does all of this connect? What is upstream? So language is confusing, and that's definitely a common thing across states. One thing that some strategies that we've seen work with other states is building a shared risk and protective factor vocabulary. So that kind of includes just making yourself and your staff comfortable with shared risk and protective factor vocabulary. One thing we hear is that shared risk and protective factor approaches are extra work, and often you're already doing this work. It's just a matter of reframing the way you talk about it, and thinking and the way you think about it happening within an IVP program. So weaving shared risk and protective factor language into everyday work helps provide clarity and how risk and protective factors connect among different programs and staff priorities. definitely think about also including administrative staff, data staff, as we talk about shared risk and protective factors, and building that common vocabulary across all staff and partners. So also when writing grants, justifying proposed strategies and approaches using shared risk and protective factor literature and language has worked for other states, as well as crosswalking your shared risk and protective factor language with your partner's language. So where you may say protective factors, a partner may say resiliency or use a different type of language. So understanding where those language differences are and crosswalking those languages can sometimes help move this work forward. So I think, and perhaps one of the biggest things that we've learned in these assessments and looking at states and where they're at with this work is that there's clearly a spectrum of work happening across the country. States are at different points with shared risk and protective factor work. Some are just getting comfortable with the terminology and how it connects. Others are developing a theory of change model and connecting this kind of work to their programs. Wherever you are, it's okay. There's clearly a spectrum of work happening across the country. So we wanted to talk a little bit about that today. I'm going to hand it over to Carly to do that.
Thank you, Eva. So yeah, as Eva mentioned, states are really all over the board in terms of where they are in their readiness to take on a shared risk and protective factor approach. And through some of our work with these assessments, we've learned that there's really, it's more so a continuum, as we've been calling it, maybe a matrix, where we can think about theoretical readiness and also operational readiness. And states can really fall somewhere on the matrix between being really theoretically ready to take on this approach and maybe not totally operationally, vice versa, or some other combination. So what we've included here is a chart where we've mapped out theoretical and operational readiness, and we've dropped some states that we've done assessments with on here, obviously de-identified, and I just want to talk a little bit about how we develop a rating for where a state is in this space. So to rate highly for theoretical readiness, there really should be across the board familiarity with upstream prevention and shared risk and protective factor approaches, and also an understanding of how people's role contributes to upstream approaches. So with our assessment, we do conduct surveys. And so when we talk about kind of these broader things, we're talking about the trends within the state. Also, we want to see, confidence and understanding of the social determinants of health, ACEs, a socio-ecological model, health equity, how all of those really theoretical public health models connect with shared risk and protective factor approach, because as we know, they do very much so. What we also want to see is that there's a perception that shared risk and protective factor approaches are both important and efficient. So, having buy-in from the people within the state, whether it be internal staff within the injury and violence prevention group or with partners. We also want to see open communication about primary prevention and shared risk and protective factors approaches, both with partners, with staff, also within leadership. We want to see those conversations being had, and an understanding of the activities that actually do need to be prioritized to focus on upstream prevention. So, IVP groups that understand what programs they can really focus on that will help in the upstream prevention space make impact down the line with multiple outcomes. And then another big piece is a belief that a shared risk and protective factor approach is in line with the visions and the goals of the IVP program. So again, that kind of goes back to the buy-in piece, but we want to see that people feel like the work that they're doing towards a shared risk and protective factor approach really contributes to the overall goal of the program in terms of preventing injury and violence. And so that's all, those are some of the main buckets that we consider when we're, grading a state for theoretical readiness. Operational readiness looks a little bit different, and that's honestly why they're not on just a linear scale. They're not the same thing. So to rate highly for operational readiness, There really should be, training around shared risk and protective factor approaches, which is something that our assessment typically leads into is training with HMA. But if states have already had training in that space, and that definitely is a plus for them in terms of their operational readiness to take on these approaches. As Eva talked about, language is very important, and it can be also very confusing. So we like to see that there's shared language across primary prevention and shared risk and protective factor work. So both with partners, internally with staff, we want to see that people know what everyone is talking about when they're using the terminology of ACEs or shared risk and protective factor, et cetera. Open communication across partners and a collaborative internal culture, obviously very important to be able to have some of those programs that are really cross-cutting. Working across partners, sectors, coalitions is very important, as is support for innovative approaches. I think something we've learned is that if there is a lack of support for innovation, it can be challenging to get some of these cross-cutting programs off the ground. And then another really big piece is an internal champion with a vision for the strategy for this work. We've seen a lot of success in states where there is at least one or maybe two people, but really there's a champion for this work, somebody who's actively trying to push it forward within the state. And without that, it can be a little challenging to get the momentum behind it. Another piece is really the availability of research, data, personnel to really carry out these approaches, and connections to organizational networks is another big piece. So there's a lot that goes into this operational piece. I would also say the absence of certain barriers. So, when we hear people saying that they have really limited capacity within a state to take on more work, that can be something that can be challenging operationally to overcome. And also discomfort changing programs. So as we know, to take on a shared risk and protective factor approach to some of the injury and violence prevention work, there has to be some comfort shifting priorities and moving funding sources around and things like that. So discomfort, whether it be, in the staff level or leadership or even at the political level, that can be challenging to overcome. So those are some of the things that we look to see when we're doing our assessments, where states kind of fall on this continuum. So what the next couple of slides, you can just give a couple examples of some states. So in this first one, we're talking about a high operational example and a high theoretical example. So you can see state G up in this, it's a little small, but this state, is somebody who they're a group that there's strong familiarity with upstream prevention and shared risk and protective factor approaches. There's open communication. They understand the activities that they need to prioritize to be able to take on this approach. And Laura, I see your note. We can definitely connect with you on that after, because Oregon, yeah, you were one of the states that we recently rolled this out. So we will connect. And then, yeah, also a belief that, as I mentioned, a shared risk and protective factor approach is in line with the vision and goals. And as I mentioned, this is something that we really get this information from, the surveys and interviews that we do across all partners and staff. And so when we're, sharing some of these things like a belief that a shared risk and protective factor approach is in line with the vision, it's really more that the majority of people feel that way. There can obviously be, some dissenting views or some contrary thoughts, but as long as the majority has buy-in, that's a really big piece of this. This state, who's really, high in the operational and theoretical space, they have very open communication. I mean, there's nothing that they're not talking about with their partners or with their staff. And also, again, a lot of support for innovation and definitely internal champions. So this just gives you an idea of kind of some of the pieces the state would have if they were, falling in that upper right quadrant. My left and right's always confused, but it is the upper right quadrant for high theoretical and high operational. And then Catherine, if you want to move to the next slide, we can talk about a state that is in that, I would call them mid theoretical because, they're right in that middle piece, but low operational. So while they do, have a perception that shared risk and protective factors are important and efficient, and there is open communication and support of the goal, and work also across partner sectors, coalitions, et cetera, they're not necessarily confident in how all of these, public health frameworks, so social determinants of health, ACEs, SEM, health equity, connect with shared risk and protective factor approaches. There's also not really a shared language across any of their primary prevention work. So, one partner will be talking about X, and staff in the injury and violence prevention group will be talking about Y, and they won't necessarily realize that they're talking about the same thing. They may not understand the activities that really need to be prioritized to focus on that upstream prevention. And again, that ties back to familiarity just with how to execute on upstream prevention. There's also, in this particular state, not a ton of support for innovative approaches. And, they're lacking funding, dedicated personnel, policy support, resources. And, one of the things that training seeks to do is provide some of those resources. So that's hopefully something that would be worked on. But then also, their current set of programs are not necessarily outcome driven. They're maybe more so driven by, the grant funding and the program. So these are just to kind of illustrate what would have a state fall into which one of these quadrants. We wanted to share this with you. So you kind of see when we're talking about readiness, these are some of the main pieces that we're prioritizing. Catherine, I think you're on mute. Catherine, I think you're on mute.
I'll get it right someday in pandemic. I'll get the mute thing right. Thank you. We want to talk a little bit next about kind of moving into operationalizing this approach. And as Carly said early on, it's not about, there's no right or wrong level of readiness, right? We're trying to understand where folks are and what it takes to move forward from where you are. But before I switch, are there questions or thoughts or reactions to what Carla and Eva shared with us that folks have about readiness or anything else specifically? Okay, well, as they come up, feel free to raise your hand or take yourself off mute or drop them in the chat. So, the way that we've worked with states is when one Safe States goes through the process of the readiness assessment, we all sit down together with the states and take a look at what does the data say, what do we learn, and what does that mean for what would be helpful moving forward? How do we design resources and thoughts in sort of thought work that can be used to shift programming, right? That can shift action in the health department, in the group. And so I just want to spend a couple of minutes kind of showing you the way that we create baselines for that, right? So what is it we're actually trying to accomplish? And then what does that mean for the work going forward? So we get a lot of questions about, what does this actually look like on any given Tuesday, right? How is my daily life going to change or be different as we move into a shared risk and protective factor approach or into applying this framework to our programming? So the first thing we want to do is to kind of make clear, do some level setting around what it is we're after, right? And so this is a definition that Safe States has established that I think is really helpful when we're first kind of thinking about this work and designing this work, right? So we're thinking about multiple population level outcomes, which usually means we're going further and further upstream, right? We're thinking about equity in everything we do, right? So the idea that this approach requires the application of an equity lens along with it is important to us, right? Because I think, again, we're focused on impacts. And so really measuring equity, measuring shifts in communities that bear the most burden as we go forward is fundamental. And then the partnership piece is really important. We talked a lot about communication, or Carly and Eva talked a lot about communication and what it means to bring the public health system in your state or in your community, your county, along with you. And so that's a huge part of how to do this work, is what is that communication? What are those languages? What does that language involve when you're talking? to partners, and how do they recognize not necessarily the rhetoric, right? It's not necessarily the nomenclature that's important, but how are you talking about concepts in ways that convey both the work and the intended outcomes, and that the understanding of that is shared across a partnership network. And we talked earlier about the social ecology, but I think we, in designing strategies, certainly thinking through the social ecology and kind of where we are trying to focus, creating some change. But it's been really helpful in states to also think about the kind of this pyramid, right? So this was created by Thomas Frieden a while ago, but I find it really helpful in thinking about the way that we implement strategies across a branch or a section, as we're thinking about grading funding, as we're thinking about what's possible, to try to get at those population level outcomes, right? To try to get at those impacts that will demonstrate where we're shifting outcomes to be in ways that are increasing equity, right? The bottom of this pyramid is really the way we want to think about some of our work, particularly given our level of readiness and in that operational readiness, right? We're working with different levels of resources, not just money, but people and infrastructure. And so while that's true, it shouldn't inhibit our ability to implement these, but we need to make sure that what we're planning can be done, is actionable based on what our existing resources are. And so again, thinking through equity from the very beginning. A lot of the states that we work with it's on their radar already. There are lots of there's support departmentally sometimes, and those things are all really helpful. But as we're moving from the theoretical right into creating real planning frameworks, building out logic models, thinking about what the priority risk and protective factors are, and then what the strategies are that will drive those outcomes. We want to keep this person in mind, right? What we want to understand is that we're talking about 80% of our health outcomes being driven by things other than what happens at the doctor. It's not shocking news to any of you, I would assume, but it's sort of thinking about that tree that we saw earlier, right? When we think about economic mobility, when we think about housing quality and access, right? All of the things that are sort of underneath the tree, there are demographic, racial components to all of those things. So how are we taking that into account when we're thinking about building out our shared risk and protective factor approaches? And I think this slide is getting a lot more play, which makes me happy. I begin to see it everywhere. But I think it does a really good job of kind of pretty simply presenting the shift that we're thinking about. When we go upstream, these are the places, these are the issues or the risk and protective factors that we're trying to shift, right? So, Laura talked about some of the work that Oregon is really trying to do. And I think there's some exciting conversations about the role that the built environment plays in injury and violence prevention, right? The ability of social infrastructure to drive connection differently is a question that we haven't spent a lot of time exploring, but there's some really exciting things happening there. And that's sort of, I think, the point we're trying to make with this slide around those broad impacts, and shift away a little bit from some of the more individual downstream risk-focused efforts. Not that they'll go away or that they ever should completely go away, but I think this broader picture is what we're holding on to. So Shannon, I'm going to turn it over to you if you are in a place where this will work.
I'm really gonna try, Catherine and friends. They are replacing the water lines in Denver in my neighborhood. And today they're replacing it right in my backyard. And they showed up just as Eva and Carly were talking. And they're like literally right outside my window. And periodically my dogs are going nuts. So I will try, Catherine. And if it gets to be too noisy, you might just have to take over.
Sure, sure.
So can you guys hear that, or can you hear me okay? Can you hear me okay?
Not too bad. Yeah, we can hear you okay. I mean, we can hear that, but it's not too bad.
Okay. So it's really, actually, Catherine, just because I think that the dogs are about to come in here because they're starting to move closer to my window. Why don't you do this part? I really apologize, you guys. Sorry.
No problem. So I think we, Carlene even touched on this a little bit in terms of, being ready to do this work and then thinking about actual implementation does require sort of a pretty significant shift in the paradigm with which we've used to approach our work over time. And there are a lot of states kind of, that are, and not just states, right? I mean, I think this is, we've begun to train some local health departments and kind of talk to groups that are full of partners, that people do generally understand the why, but then again, the question of how, what does this look like when you're actually engaged in the work, right? And so we start with these sort of steps around a paradigm shift that I think are pretty applicable across the board, right? But thinking about the planning that you're doing, how all the strategic plans or all the program plans, right, as we drop into grant writing, prioritize a shared risk and protective factor approach, right? So that we can, so that's sort of the first step in breeding funding, right? Is making sure that it's well thought out logic that's justified in work plans and that we can demonstrate how the work fits together. Thinking about what, often we, funding often chooses us, right? So sometimes we see opportunities and we're less strategic in how we go after money because we need to shore up positions or do things like that. Whereas thinking through how to do that with a shared risk and protective factor approach, I think broadens our ability to prioritize funding, right? To understand how things can be more connected and potentially make funding opportunities more useful to us, right? But that we need to think about which ones will best serve this work. And think about how to broaden our planning, right? Even if we have a collection of plans that are based on shared risk and protective factors, how are those, we've set those up hopefully so that they are the same shared risk and protective factors, right? So we're building a network of complementary programs across the branch. And thinking about staffing appropriately and strategically. And this can be a challenging one, right? Because we often hire staff based on subject matter expertise, right? I got hired a lot in my career because I know a lot about sexual violence and sexual violence prevention, right? But never once was I hired because of my suicide prevention expertise, right? But then, when we think about applying a shared risk and protective factor approach, we have to begin to understand what those two bodies of work have in common, right? And then how to strategize and in our hiring practices, but also in our onboarding practices, how are we preparing people to think about our work differently when they come into a branch or into our health departments or our organizations doing this work. And then building through that an integrated organizational structure, right? So we may not necessarily in the long term be organized by content topic, right? But we might be organized by some aspect of the work or by a protective factor that we prioritized to drive all the work forward. Shannon, I don't know how the noise is on your end, but did I miss anything? Is there anything you want to add here? No. And I don't have, sorry, I'm not able to watch the chat. So Eva, Carly, maybe one of you can monitor that while Shannon is sort of dealing with the dogs. But so again, going on in terms of how we're making structural changes to increase our ability to better implement shared risk and protection. And these processes are often, they're developed over time. So I don't want to give the impression that this kind of a paradigm shift has to happen before you begin, right? This is the kind of stuff that you build and work out as you're moving forward. Leveraging funding, right? So early on when Shannon and I were in Colorado beginning to do this work, one of the first things we did was go to CDC and say, we want to use our RPE carryover dollars to fund some strategies, to fund some programs that do teen dating violence prevention and then do bullying prevention with a specific focus on homophobic bullying, right? We want to target those two things because there were early research suggested that those kinds of behaviors were also related to sexual harassment, right? That if we could shift risk factors that drove all of the perpetration in these three areas, that we could really build an efficiency into how we were doing some of our programming, right? So we had to write some justification to CDC. We spent a long time trying to convince them that we could do this kind of thing. And so leveraging funding, right? Really finding, at the federal level, there seems to be less convincing that's necessary, but I think that funder education is always a big part of this in terms of getting some of this programming off the ground. And I think there were some great examples about how to frame the work early in the presentation earlier. Cross-training staff, right? So how do we, again, like to my earlier point, right? How do we prepare staff to be more nimble, right? To be able to speak across issues in ways that are helpful and contributory. And to be able to design programs with the needs and understanding of multiple issues. Communication is huge. We heard a lot about this in the readiness conversation. But I think even this morning, we, kind of in how you communicate to CDC, right? How we're framing our work to get funding, how we're framing it outside. Not everyone does or will ever use the phrase shared risk and protection, right? And we probably shouldn't use it a whole lot outside of the health department or outside of our organization. But again, I think the language, the specific words are less important than making sure that the concepts we're conveying are understandable, clear, and that they're shared by the partners, right? They're shared by that people we're speaking to and people we're speaking with are giving those consistent messages. And then, as always, when we talk about the things we do now, the community sort of, how is the community leading this, or how is this reflective of communities and community priorities? And then, I've talked a lot about funders up to this point, but I want to highlight the second sort of point that I have here around, we hear this a lot in states. There is a fear of what's going to happen, but also as actual feedback, right, that we're getting from our partners, that we don't want our issues to get lost. Partners don't want their issues to get lost, and for good reason, right? That we've worked really hard to put a focus on sexual violence on the radar, right? I mean, when I first started doing sexual violence work, we had exactly two evidence-based individual level curriculum that we were working with, right? We didn't have a lot of money. And so this strategy really gave us a way to connect our work to other work that both got resources into preventing sexual violence, but also got more conversations happening that we were included in, right? That we could use to push our work forward. So we need to make sure those superordinate goals are shared, understanding that programs may still have specific strategies that are framed a little bit differently, or we are still talking about rape culture when we're doing RPE work because it's important. But that may not be the language that we're using to talk about the importance of gender or how we need to think about gender roles when we're doing other types of prevention. And then measurement. So those of you who are out there who are evaluators, I think the coming few years will be your moment to shine, right? How do we begin to measure this? And not just measure this in the way we historically have done, right? I always liken it to agricultural chemicals. I don't know how many of you are farmers, right? But we have a lot of understanding of what happens when you put one chemical on a field. We'll put one chemical at a time, and that's how we test it, right? But what we're learning is that when you put a whole bunch of chemicals on a field at a time, they mix together and they do things that we maybe don't understand, right? And so I think understanding the benefits and kind of what happens when we apply these approaches comprehensively is a really exciting. We're ready to start doing that. Some states are really ready to start doing this, and I think it's exciting. I think CDC also has money now in the field that's supporting this work, and so that's all very good news. Shannon, anything I missed on any of these slides that you want to add? No? All right. So we want to give you a chance now, so let me pause for a second. Questions, thoughts, additions for those of you that have gone through some of what I already talked about, what you learned when you were doing, kind of making those changes? Feel free. Go ahead.
I really think that having Shannon have to drop off is just this perfect example of what you're talking about. You have multiple partners for multiple organizations. So when one is compromised, the project itself has not stopped. And I mean, I think you're even looking back to like the previous example, you're kind of undermining that, pull yourself up by the bootstraps, or like, you know, everybody's competency relies on, you know, their performance, and you've really come together as a team of 3 people to continue this work when one of the components was taken out. So I think it's you know, and you know, talking about how to communicate the benefits of this to our partners, I think this could actually be an example where, you know, we had this program and the program didn't stop because one of the partners couldn't continue, and by working together and supporting each other, you know, I'm not seeing Catherine like shaking her head and like, oh, I have to cover for Shannon. I think it's just a really good metaphor for exactly what you're talking about. So yeah, I think you planned it. But I think we could use these type of stories too to show our partners who are a little skeptical, like how beneficial this shared risk and protective factor and working together can be.
I love that, right? And I love it even we could think about it like funding sources as well, right? We've talked to a lot of states about, you know, what happens when the core priorities shift or when funding goes away, then we often just stop measuring outcomes related to whatever it was we were focusing on, right? And the potential to maybe not have those interruptions happen at all, or to the degree they do, is the same kind of, that's a similar metaphor for exactly what you're talking about, that measurement piece. So I love that. Yes. We planned it. I wish we were that smart. Although I would have planned it the other way around. So Shannon was talking.
Well, it also speaks really well to your point about cross-training, because I think I know our project gets stalled when we have someone quit. And so, you know, the training didn't stop because Shannon had to quit. You know, you all were able to step in. And I think this is a great example. Great metaphor, guys.
Great, thank you. Other questions, other thoughts? All right, so now what we want to do is we want to give you a chance to kind of take what we've talked about, take what you heard this morning, all that excitement, and we begin to talk to each other, right? Because part of our goal, both with this conversation and then in the work that HMA and Safe States is doing, is to really, again, bridge this gap, or this sometimes gap, between theoretical readiness and operational readiness, right? So we want, what do we know, and then how do we apply it, right? And we get really stuck sometimes when we get to that, how do we apply it? And the fact that some things may not change at all, some things will change a whole bunch, right? So what I'm gonna do is, we've got some questions for each of you. that for groups that we want to have conversation. We want to give you all the chance to talk to each other and kind of digest a little bit. So I'm opening 3 breakout rooms, and these 3 breakout rooms, let's see, are described here. We're going to let you self-select in, right? So if you are part of a section or a health department or an organization that's just beginning to explore what it might mean to take on a shared risk and protective factor approach, we have a breakout group called Early Exploring. If you are engaged in conversation and maybe you have some efforts going on, whether they're pilots or kind of efforts in parts of your branch or your section, we have a group called Engaged in Planning. And I know these names are imperfect, but we're basically trying to get at, sort of what your level of activity is. So bear with us there. And then if you are actively implementing shared risk and protective factor work, or working, you've got programs going, you're wrestling maybe with some evaluation, you're thinking about those things, we've got a group called Actively Implementing. So we're gonna let you self-select in, and then each room will have a facilitator that will just kind of help with the conversation, walk through some questions. We want to talk about OD2A specifically. So I just sent an invitation. So if you click on the breakout rooms, you'll see where you have an option to put yourself into a breakout room.
Looks like we are back.
So. And Shannon, you're quiet now. You're
periodically. They're still barking just for good measure, just to make sure that those guys are gone.
So I think we have about 15 minutes left. And so what we thought we would do is just maybe hear a little bit about what that was like. Any big lessons or ahas from any of the groups? How the questions go? Were the conversations good?
I can chime in for my group a little bit, and please, group members, feel free to talk over me or chime in at any point. But we were in the, I forget the name of it, but I think the Actively Exploring. So, starting to think about the potential of engaging in shared risk and protective factor approaches. And some of the things we heard are, really pretty unsurprising given some of our work with the assessments, that there are challenges in terms of trying to move the work upstream and needing, partner buy-in and having people kind of not necessarily always be on the same page, and needing, a champion within the state or within the county to really push that work forward. So those are just some of the things that kind of came up as barriers. So yeah.
Is that like a communication issue, or is it sort of getting partners on board, or getting funders or support? Did you get that deep into the question?
It seemed like a little bit of both. So certainly a communication, issues with language. And again, Emily, I know that this is a lot of what you were talking about, so feel free to jump in. But yeah, issues with language, certainly, and not necessarily knowing that everybody's talking about the same thing, but also partner buy-in, and just needing somebody who is really leading the approach, I would say, and knowing who's in charge.
Yeah, I know Micah mentioned like shared language issues is something that they were dealing with. And then Maureen had mentioned like kind of who's in charge of the things to try to get things together. And mine is kind of like we've been kind of like building on it. So we're like maybe like halfway, but issues of like making sure that there's buy-in, like not even from like a financial perspective, like not even like I would like your money to help pay for this program, like please come to the meeting, which I mean, I guess that does, like if you're having someone use their paid time to come to a 1 hour long meeting, like I suppose that is a use of funds, but even like just the play in the same sandbox kind of thing. And like, I feel like there's a lot of like convincing people, like, it's great, like we should work together, especially like this makes sense, but which I think it does for some people. I think especially maybe like the people who are on the ground doing work, like different, like sometimes that makes sense because I previously was in like an RPE contractor position. And so I was like, yeah, I can't do all of this by myself. Of course we should work together. But then like, are there other people doing prevention work in the area? And like, what are their restrictions and things like that? So like we had buy-in from like RPE, like going up, like all the way up, but then, you know, a different grant program, like maybe not, there's some other priorities. And so it was kind of it was helpful to move the partnership forward when I had like something that I could offer them. And I was like, please come teach sex ed with me. And they were like, done. And so then we became friends and started working together more, as opposed to like, you know, I guess like maybe they're full up on the amount of friends that they have, and that is okay too. But I a little bit feel like I always joke that like trying to get people to like, oh, like work with me, like, let me show you all the tricks I can do. I have 4 dogs, so I can really, all of the barking, I was like, oh, I'm at home. But like, look, I can high five, I can spin in a circle, I can do all of these things, and please be my friend. And they're like, nah, you're a lot, so no, thank you.
What about other groups? Like, I mean, spoiler alert, right? Some of that doesn't go away, right? So, and no matter which group, right? So are there groups in other states that maybe dealt with that or had reactions to that? Like, oh yeah, I remember those days, or we're still in them? Those early partnership communication days. I mean, we feel like that a lot. And Shannon, I don't know if you want to give your spiel about partners, right? About sort of what that, some go away, some stay, right? Like it's, you know, just like any sea change, right?
Yeah, I mean, I always say that it's okay, like that not everybody will move with you as you move further upstream and do more primary prevention work. And that's okay. Like you'll make new partners, and you'll lose partners, and the partners that you lose will keep doing their good work in whatever area that they're doing their work. They're just not going to be doing it with you. And that's fine. And Catherine and I always chuckle because some of those partners that we lost, we gave them a clock and we said, thank you for your time. And and they moved on and did their work, and we did ours. And it can be really hard, and it can feel strange, but you have to be okay with that. You have to evolve and evolve your work. And sometimes it's really hard for us, especially in public health, to do that. We feel like we have to be friends with everybody and play with everybody. And you don't, that's not strategic. So just food for thought.
Anything else from the beginning group? What about the middle group? What about the sort of beginning to engage in implementation, maybe further along in planning, maybe doing pilots? What about that group? What did you all talk about?
Well, I don't want to speak for my whole group, but I'll give you a little bit of what was talked about. So, you know, I think from this group, everybody is bought in with the shared risk and protective factor approach. The theoretical understanding is there. People feel confident with this is the approach, this is the direction we want to go. But they're in the process, you know, somewhat similar to the beginning group of just getting people on the same page, getting partners aligned in that work, and also getting their actual programs aligned into that kind of approach. So, you know, that can be a little bit difficult when there's a lot going on at once. So that was definitely one thing that we talked about in our group. We also talked about having the more examples of states doing this kind of work or programs doing this kind of work, the easier it is to, you know, use those examples for yourself and for their work. So a lot of interest in seeing examples of states doing shared risk and protective factor approaches so that they can, you know, kind of imitate, I guess, or to carry that work forward. So my group, feel free to add, please, what you took away from it.
Yeah, I think, we're seeing a lot of similarities or a lot of overlap, right? Not exact overlap with states in terms of some of the priority risk and protective factors that are being chosen, right? There's some, we see more difference when we get to the strategy level, like how people are trying to drive change there. But I think there's a lot to talk about there and a lot to share there. Stephen, did I interrupt you? Were you going to say something? Is it Stephen or Stefan? Oh, you're on mute.
You would think after 18 months.
You know what? You're my kindred spirit. You are my kindred spirit.
You would think I know to push this button. And this. Well, anyway, I didn't have any questions. I was just logging in. We have a presentation a little bit later on, and we're just catching the tail end of your presentation.
Oh, excellent. Excellent. You're on camera. I didn't know if that's because you wanted to talk. So yeah.
I probably didn't know that either. Well,
what about the?
We'll see you in a little bit.
All right.
All right.
What about the last group, the actively engaged group?
Yeah, we're a pretty engaged group. We got high energy here over at DC Health. So we're going to finish strong.
Excellent. How about the last breakout group? How did you all fare?
So we had a great discussion. Nice to spend some time together. I think that, I know we're running out of time, but the key, I think, takeaway, at least for me, and I would invite others to chime in, was just the hearing from the community level kind of folks and how this is translating for them and the work that they're doing. And Lisa, I really think that you said it best, like just having some flexible funds for communities so that they can do what works best in their communities. And it just reminded me, like, the idea that communities really, solutions come from communities. And so having communities identify the solutions that work for them and implement those solutions. So excellent. I don't know if anybody else in the group wants to say anything.
I'm just going to piggyback on what you said, Shannon. In Oregon, we've really been looking at how to fund communities with a more low barrier structure, because I don't know about the rest of you, but the way we fund things in Oregon is really hard. It's hard to get contracts through. It's hard the reporting is hard. Everything's hard about it. And that kind of tends to rule out smaller groups because the money sometimes isn't worth it. And so Laura, my manager, is gone, but she did an experiment we actually had some COVID community funding for LGBTQ mini grants. And she put out an RFP to make it as simple as possible. And it was unbelievable what the communities came up with, things that at the state level we never would have thought of. Just beautiful dance projects, drag queen story hour at libraries, all kinds of just amazing stuff. And it was really encouraging. So we're currently working on restructuring how we fund communities because of that.
Yeah, that's pretty exciting. I worked with a foundation that recently did some work where they were able to help communities build co-ops, right, and build wealth and land security for grants that were smaller than $10,000, right? That's what they needed. That's what people needed to hire an attorney and figure out how to do to build co-ops for themselves in the middle of Asheville, North Carolina, a city that's being gentrified really, really quickly. So I think that's an exciting idea, right? In terms of let's not get limited by the fact that we need $100,000, right? Because communities are full of resources. So Kate, I know we're running over a little bit. I promise this is my last slide. I just want to give a plug, and Eva or Carly, jump in just really quickly if you want to just give a plug for the Connections Lab before we wrap up.
Yeah, definitely. Really quick, please check it out. The Connections Lab provides you just with a definition. It's the first, what we're calling first definition of shared risk and protective factor approach. I mentioned it earlier that it's a great way to, it gives you a conceptual framework for how a shared risk and protective factor approach can be used. So it's a great tool to kind of use and think about in line when you're thinking about your own work and how it connects to shared risk and protective factor approaches. So there's tips and guidance, examples of shared risk and protective factor approaches in practice, tools and resources, and a glossary. So please check it out.
Excellent. Feel free to reach out to any of the four of us if you have questions or need anything else from us. We can share the slides, be helpful in any way. And thank you so much for the opportunity. This was a lot of fun.
Thank you, Catherine and everyone for a great presentation and discussion. I am also really excited because I think hopefully in the future we'll have more opportunities that we can coordinate for you all to connect with Safe States and HMA. So look out for that. And Catherine, yeah, if you can send over the slides, I'd love to send those out to folks in the coming days. So thank you so much. We are next going to hear from DC, but before we do, we're going to take about a 10-minute break. And feel free, I know that this kind of stretches the day. If you need to grab lunch or whatever, you know, and bring it back, that's fine too. Take breaks as you need. But yeah, I will see everyone back here at 12:45 Mountain Time, so 2:45 East Coast time. So let me know if you have any issues. I wanted to welcome our DC team to take over in a minute and introduce themselves and talk to you more about the work that they've been promoting, that they've been doing in DC around promoting equity through harm reduction. I'm going to let these folks introduce themselves. Stephen, do you?
I'm Nestor Rocha, and I wanted to welcome everyone to our workshop. We are going to present to you how the DC Department of Health basically work towards promoting equity through harm reduction. This is basically the DC experience. For our agenda today, we wanted to address 3 different areas. First, I will start with a quick overview of what the epidemic looks like for DC. Just a general perspective on the profile of folks who use opioids in the District of Columbia, how they are impacted, and what social determinants of health are involved in this population. Then how we basically work towards identifying opportunities for us to integrate equity and addressing some of those social determinants of health for the population that we serve. And then third, just sort of a description of how our program is formed and the different components that we include in the work that we're doing. And then last, we'll open up for questions and discussion. So meet our team. I'm not sure if you're able to highlight the pictures that all our speakers are basically on camera. At the top left, it's me. Again, I'm Nestor Rocha, and to my right on the picture is Stacy Cooper, who is Deputy Chief of our division. Then below to the left, Malachi Stewart, who is he just recently joined us and is already doing a fantastic job, basically helping us build our programs. To his right is Sharday Lewis, who is our behavioral coordinator. And then to the right of that is Stephen Reeves, who has been basically our harm reduction coordinator. And last but not least, it's followed by Shay Davis, who unfortunately is not going to be joining the presentation, although she did take part in the creation of this presentation. So that's our team. Okay, opioids in DC. We are, like much of the rest of the nation, have seen an increase in overdoses that have impacted the District of Columbia. We have definitely seen a disturbing number of fatal overdoses. We, on average, are seeing about 34 per month. This year alone, already have seen 62 opioid overdoses that have taken place. We definitely know that a lot of this was a direct result of the impact of COVID-19, the way that it disrupted services, the way that it disrupted availability and access to services. We've seen other challenges that were involved with COVID, such as our inability to be able to get people, link people quickly and effectively into treatment, because most places were working virtually. And as we know, this population actually needs pretty much on-demand services. And so working with virtual platforms was not necessarily the most conducive. With respect to fentanyl analogs, we find that at least 94% of any samples tested do carry fentanyl. And what we understand from our from feedback from our providers about our population is that the challenge that we're facing is actually much larger than we expect. Or than we actually knew, because while we're working with our community to educate about the concern and the risks that using fentanyl can actually pose, what we are finding as an experience and we're hearing is that folks who are using opioids are actually intentionally looking for fentanyl being present in drugs. And so it's making our job a lot more difficult. It's an uphill battle. And then just a picture of what the user population in DC. There are some stats there that you can see. One of the things that we know we are markedly different than the rest of the nation is our users in DC tend to be more long-term users who are actually then victims of overdose incidents. As you can see in the stats, at least 88% have been using for more than 10 years. You know, basically it is a very different population than we actually see in the rest of the country. So in terms of our profile, one of the things that I would first describe is that the map of DC, as you can see how we're divided, those are wards, and there are 8 wards in DC. Basically, the yellow bubbles in this map is actually showing how the distribution of incidents of overdoses are taking place. As you can see, basically, it is all over DC. It is a major concern and a crisis in general. In addition to that, we can see that there is high concentration in certain wards, specifically mostly in 5, 7, and 8, which are the most affected. As I mentioned before, the age average for our users basically is older users who have been long-term opioid users. We find that almost 80% of fatal overdoses actually happen among folks who are between the ages of 40 to 69. And 89% of DC opioid users are over 40. So we definitely are seeing a population that would be very difficult to reach, especially because of the long-term use. As a matter of race, 84% of all deaths for opioids actually happen in African-American community. And that also applies, it's equally to our non-fatal overdoses. So it's mostly African-Americans who are affected. And with that also, in terms of gender, it's mostly African-American males who are really victims of fentanyl and opioids and who are actually experiencing the larger number of overdoses. In terms of location, as I mentioned before, wards 5, 7, and 8 seem to see the highest concentration of overdoses in the city. So focusing on those wards, and you can see the numbers here, 5, 7, and 8. we are looking at a population that is for certain facing already tremendous challenges when it comes to structural and social determinants of health. We are dealing with communities that have been disenfranchised for quite some time, where, for example, the life expectancy is essentially much lower than the rest of DC. Where educational attainment is much lower than the average for DC as well. And so we are really looking at populations that see very little opportunities for actually just simply advancement and just not engaging in these particular types of lifestyles. They're more than likely to be unemployed or underemployed at a rate of about 13 to 30%. This is versus the entire DC population, which is 9.6% unemployment rate. More likely to live in poverty, which I'm sure everyone can imagine. And up to half of all households have no access to a vehicle and are dependent on public transportation. So this basically would impact their ability to access food, housing, and other services. In essence, basically are located in sectors of DC that also have limited services available and limited access to services and benefits. So with that, I will now hand it over to Stacy Cooper, who is going to touch on where we began to find opportunities at HASTA to be able to try and shape our programming and bring some equity to the work that we're doing around harm reduction.
3 o'clock.
Stacy, you're muted, just a heads up. If you want to unmute yourself.
Thank you, and I was trying to be so prepared. So as you can see from the slide that it says the quality of being fair and impartial. So as we were moving forward, as Nestor was going over the populations that we serve and how the community appears, HASTA looked at ways to make sure that funds got out into the community and got to just the right populations that needed the funding and programming. So up until 2018, HASTA had been supporting programs through federal and local funds through a grant competitive process. And after 2018, we started to look at that and wanted to make sure that we were getting the best services out to the community and that the best providers and vendors were at the table. So we moved to a unit-based cost or human care agreement that was used to support providers, and they received reimbursement for the effort that they put in. So linkages to care would have had its own rate, an HIV test had its own rate, and that was how we continue to support many of our programs. Our harm reduction programs, though, are still mainly supported through a competitive grant process. So as you know, this whole presentation is about equity-focused harm reduction. So with that, we decided and we work on 3 pillars. One being community-based, the other being peer-led, and the last being capacity building. Community-based is where we're building partnerships and relationships with community partners that are most in contact with people who inject drugs and people who use drugs in the community. Peer-led is where we work with people who have lived experiences and make sure that they are at the table and that they take a role in the development and the procurement of programming. You'll hear more in our next couple of slides about our Rapid Peer Responder Program, which is really at the forefront of our peer-led programming, where those individuals are working directly with people in the community who may have overdosed. And then capacity building is our 3rd pillar. And these are strategies and activities that we use to make sure that we are using the best interventions and the best programming that supports the community as well as the providers that we work with. And from here, I'm going to pass this on to Malachi. I'm sorry, Stephen.
Malachi. Well, thank you, Nestor, for framing the situation in DC. We have a unique situation, as you mentioned, and you provided great insight into our particular situation. And thank you, Stacy, as well, for framing our approach to address this situation. I'm going to talk about the community-based efforts we have. As you mentioned, Stacy said we have 3 columns or 3 pillars. We have community-based, we also have capacity building, and we also have, I cannot think of the third one, capacity building and peer-led. I'm going to talk about our community-based efforts. We have 4 syringe services providers, and we have exchanged over 400,000 syringes thus far during this fiscal year. These programs provide essential services to people who use drugs such as wound care, vein care, and we also pass our basic harm reduction products. The syringe services also has 3 mobile units, and that was very integral, especially during COVID, because a lot of our clients were already isolated, so we had to take the services to them. So the mobile units were very, very useful, especially during COVID. We also have a program that supports our MAT efforts, and we call the program BUPDAP. It stands for Buprenorphine Drug Assistance Program. It covers all 5 medications that are used in MAT, that being buprenorphine, Suboxone, naltrexone, naloxone, and Vivitrol. As of today, we have 332 clients enrolled in the program, and we've had 884 claims since the program opened in November 2019. This is one of our most popular programs and is set up to be a stopgap program until our clients receive traditional insurance. It covers pharmacy fees, medication fees, and as well as copays. I mentioned MAT earlier, and we have 8 providers that provides medication-assisted treatment. We cover the entire district, all 8 wards. These needed services employ various methods, including peers, all of them include peers, mobile units, and community conversations. The community conversations educate the public, and the public educates us about what's important during this epidemic. As Nestor mentioned earlier, it was through one of these community conversations that we found out about the presence of fentanyl and its high demand. Also, we provide crucial medications during our MAT programs, and we set them up so they can be linked to primary care services. So we don't only treat our clients' OUD needs, we also treat their whole health needs. We employ also wellness services through some of our MAT programs, and we even have some that are dedicated solely to women who are experiencing homelessness. We're also fortunate enough to provide virtual instruction through the Opioid Learning Institute with our health partner, Health HIV. OLI, also known as the Opioid Learning Institute, provides district-centric medical and healthcare training to our doctors, social workers, and nurses who work in the opioid field. With 16 different medical modules present in a virtual form, our clients can access this needed information 24/7. These are not just PowerPoints, they're interactive, they're entertaining, and they are asynchronous. So our clients don't have to leave, our partners don't have to leave our clients in order to receive the needed, most up-to-date training and technical assistance available. So we're very, very proud of OLI. I mentioned earlier about the community conversations. They are designed to happen in all 8 wards, but unfortunately COVID hit and we had to pause having those face-to-face meetings with our partners in the community as well as within the medical field. But the community conversations will resume, or have resumed already as of March 2021. So that's our community-based efforts. And now I will turn it over to Malachi to talk about our peer-led efforts. Malachi, you're on.
Thank you, Stephen. And so as Stephen pointed out, Stephen unpacked sort of for us what the community-based aspect of this like equity focused harm reduction initiative looks like here at DC Health. And so I'm going to unpack more of what that peer-led aspect looks like. And so the peer-led aspect sort of can be divided into three parts. You have your rapid peer responders, ACV peers, and community-based outreach teams. And so to sort of explain what each one is, the rapid peer responders are people who have lived experience, who experienced an overdose before, and who are able to go out into the community and to use rapport to link people to treatment and to services that are provided in the community. The HCV peers, so with hepatitis C, there are 4 different providers that work with us, and so we are able to embed peers in those 4 different providers, and they're able to talk to people again using rapport to link people to testing and eventually to treatment. Lastly is our community-based outreach teams. And with the community-based outreach team, throughout the city, there are 6 different CBOs that work with us. And so through DC Engage, peers are able to work to get people, to work with them to coordinate opioid prevention education. And that is happening across all 8 wards in DC. So the goals around this and sort of how that falls in line with the equity approach is that we're hiring individuals who have this lived experience. And again, as you can see, as I talked about with the rapid peer responders, the HCV peers, and the community-based, everything is really kind of depending on rapport. That's going to make more sense later on as I go over a case study and kind of show you what all of this looks like in real time and how it looks for individuals in the community. It also reduces barriers for the community because we're hiring peers. So people who would have had resume gaps and may have faced some employment challenges, this sort of addresses that by hiring the people that we're serving. It also provides connections and sustainable employment relationships, and we strive to provide a livable wage of a minimum of $20 an hour. So next, I'm going to turn this over to Sharday.
Thanks, Malachi. So I am going to finish kind of the conversation on the 3 pillars of our work and talk through our capacity building initiatives. And the first one I'm going to discuss with you today is our new harm reduction vending machine initiative, which we are planning to launch officially in the next few weeks. So we are really, really excited to be working on this, and we are seeking to make DC just the 3rd jurisdiction in the continental US to launch anything like this. So the components of this initiative that I really want to draw everyone's attention to, because again, this is how we strategically kind of connected to that equity focus, I'm going to talk through right now. So the first one is that it's community focused. So we were really intentional about building in kind of components that force communication and engagement with the community. So we are funding 2 separate providers, and they will support the launch of 6 different vending machines. But in partnership with that, or in concert with that, they're going to have to work with their local communities on things like where those vending machines will be placed, what those vending machines look like, and even what specific kind of materials are available within those vending machines. So we understand that those folks who are kind of closest to the issue are also have the best kind of ideas around the solutions, and we want to make sure that we're really tapping into that. So we've been really, really intentional about making sure we have a really strong community focus with the harm reduction vending machine initiative. Another integral approach to this is that we want to be looking at this from a whole health perspective. That is something that is kind of a paradigm shift for the traditional medical approach, especially within kind of the treatment and recovery spaces. And we want to make sure that we're giving folks who use drugs and these other marginalized populations a real opportunity to expand the perspective on what their health looks like, so that we're including components about wellness, so that we're including and taking into account their social and structural determinants of health and how we support their care moving forward. And kind of lastly, the most important thing that I want to focus everyone's attention on is that these vending machines will provide low barrier access to folks all across the district. So this is really going to enhance our constituents' ability to access wellness materials, HIV prevention materials, and harm reduction materials and services kind of outside the traditional hours and walls of what business and treatment currently looks like. So we are, again, super duper excited about this. As you can see through those kind of three components, this really significantly ties to that equity focus and kind of demonstrates how we're really trying to embed that lens into all of the work that we're doing. The next program that I want to talk to you about is DC Engage, and you will have noticed that Malachi mentioned this a little bit earlier because we have some peers that work through the DC Engage program as well. So DC Engage is ultimately really a program about building a strong pipeline of harm reduction providers and services within the district. And this really ties to our equity focus specifically because DC Engage was really structured so that we could get at organizations that were smaller or kind of less established and make sure that they're getting some practice and infrastructure development so that they can engage with our larger funding opportunities more consistently. So there are kind of three pillars of our DC Engage work. We've hired or contracted a core TA provider, Health HIV. They also manage our Opioid Learning Institute that Stephen mentioned earlier. So they are really embedded in a lot of the opioid prevention work that we're doing across the city. And then we have some directly funded agencies, and these are just kind of smaller agencies that are already established but may not have been working in the harm reduction space. And then thirdly, that third column is kind of our micro grantees. And our micro grantees are really like coalitions and kind of loosely associated networks. And again, this is really about building their capacity to support and deliver kind of harm reduction services throughout the district. So this is really our way of reaching those smaller agencies or folks who are not in the harm reduction space yet and giving them the assistance and support that they need to bring them into the space. So just drilling down into what that looks like a little bit further, I'm going to start talking about the directly funded agencies, of which we have two, our Southeast Family Strengthening Collaborative and Prestige Community Resources. So Health HIV really works with these two agencies to help them build a sustainable plan around the integration of harm reduction services in their agencies overall. So this always starts out with a really in-depth needs assessment. Then we kind of bring in their leadership and create an overarching kind of training and TA plan that is held up through kind of monthly coaching, monthly training, support on naloxone, leadership coaching, and other kind of infrastructure development support. So all in service of implementing and executing that larger plan that was developed out of the results of their needs assessment. So that's how the directly funded section works. And now I'll talk you through the micro grantees. Our micro grantees are a little bit different. Again, they are coalitions or looser networks. They're not necessarily all established agencies, and they will be working towards implementing more concrete harm reduction projects within their spaces to kind of bring them into this harm reduction space. So some sort of highlights of those activities really include, they're all working on naloxone distribution. Some of them are working on creating drop-in centers, awareness and social media campaigns, facilitating online conversations, specifically within the LGBTQA community. And we know how important that online kind of engagement has become in light of the pandemic. So really building out that kind of telehealth chops is really important. And then another really, I think, innovative and creative look is that a lot of our teams are in the faith-based space. So they're doing a lot of work, not only on getting folks trained on naloxone and overdose reversals within the faith-based space, but also actually working with clergy on how to integrate these messages into their sermons and into their other kind of materials that they're creating. So this ultimately, again, shows how we are really trying to intentionally think about creating a pipeline of stakeholders and partners and providers who are equity focused and in the harm reduction space in alignment with kind of the other two pillars of work that fall under this bucket. So I'm going to end up there and I'm going to turn it back over to Malachi, and he's going to walk us through kind of a case study that again shows all three of those buckets and how they work concurrently and in an intertwined way.
Awesome, thanks Sade. So I'm really excited to share this case study that can kind of give an example and sort of like a real life example of how those concepts of community-based, peer-led, and capacity building all work. And so it's also an opportunity to be able to brag on a coworker. And so I want to share with you Ryan Jeffries' story. So Ryan Jeffries is a 60-year-old African-American veteran. He had a history of drug use, and so he was in long-term recovery from using heroin and other opiates. And so after 20 years of incarceration, 8 months after that, he was hired by DC Health to be a rapid peer responder. It was through his work as a rapid peer responder that, through again that rapport building, that he was able to come in contact with a man named Clark. Clark shared with him as they continued to build rapport and relationship. He was able to provide Clark with Narcan initially, and then he was able to get Clark connected with MAT. He also, full wraparound services, was able to call a yellow cab and have him transported to FCMS. When Clark got to FCMS, he was enrolled in BUTAP, and then he was able to receive his medication there. That way he would be able to receive his medication while he was waiting for his insurance coverage. Ryan has, through his work with Clark and different clients throughout the field, he has been able to be recognized, not just from the RPR team and DC Health, but he was also selected to participate in a panel that reviewed grant applications for other harm reduction programs at DC Engage. So this is a wonderful example of sort of how the equity-focused harm reduction works for the community and the people that we're here to serve. And now we'll turn it over to Nestor.
Okay, so you've heard from our programs. As you can see, we've tried to create a portfolio that actually sees opportunities for equity on two different ends. One is working directly with individuals who actually can really provide a lot of value to the activities that we're trying to do and the aims that we have, but also at the structural level where we have done a lot so that we can possibly expand and foster a wider network of programs where we're really providing opportunities and access to small organizations that actually may not really be competitive or otherwise may not have really an opportunity to receive public funding because of the populations that they work with or because of lack of sophistication in terms of programs, computer systems or other systems that don't allow them to actually apply competitively to public funds. So that's how we've been working since 2018 to try and sort of shape our system so it becomes much more accessible to everyone. So at this time, we'll open up for questions. First, I will acknowledge that there have been some questions already posted in the chat. I'd like to thank Stacy and Stephen. I think that you've been spending time responding. If there are additional questions, basically you can just go ahead and either add them to the chat or I believe you can unmute yourself. I'm not sure. I will ask our moderator about that.
Yeah, you definitely can unmute yourself. And if you'd like to chat questions, and I'm happy to read those off as well. And I just wanted to also say thank you so much to your whole team for presenting. That was so helpful and informative, and I think a great example that a lot of folks can learn from as we try to make sure that people with lived experience or groups that are typically underfunded or not funded can have opportunities to be experts in this field. So thank you so much for sharing all that. And yes, please unmute yourself if you have questions or comments, or chat into the chat box.
I am curious about, you guys seem like a pretty small group of people, and I'm just curious about the general approach you take to creating these really large projects that are really cool, by the way, but how you do that with kind of it seems like a small group of you. Is it more the organizations that you work with that you do it through, or are you more of like a board that oversees, or I don't know, tell me about it.
So I'll start that answer, and then I'll allow the team to weigh in. But in simple terms, we actually try and build partnerships and build collaborations as much as possible. There was a question earlier in the chat that I responded to, for example, as to what funds these programs, whether if it's all OD2A. And it's not. It's impossible to have this level of programming with only one funding source or stream. So we've looked to maximize, for example, the use of that funding, as well as the use of state opioid response, but funds that are coming from SAMHSA. But we're not the recipients of that. What we did is we basically established a collaborative relationship with the Department of Behavioral Health, who then actually has looked to us to be able to provide some support around harm reduction, because it really lies in us, the experience and the expertise in harm reduction, because we've been running our syringe services program since 2007. And so therefore, a lot of our programs are already poised to be able to expand on that. At the community level, I would say that similarly, it's mostly around engagement and building of collaborations. And what I mean by that is, this is work that we started doing quite some time ago, which is trying to engage providers, communities, community partners in ways in which we try to maximize shared vision and missions. We know they're working with the population. We know they serve the population. So we either find ways in which some of the activities can be layered into existing programming, so it doesn't really require additional funding or work or additional staffing on our part, because it is our community partners who are taking this work out there, or otherwise looking for opportunities to layer in the additional service and provide a limited amount of funding so that it can kind of help that. And that's for one perfect example of that is the micro grants that Sharday described. I hope that answers your question, but I would like to allow for the rest of the team to weigh in.
I mean, the only other thing that I would add, and I think it's important to acknowledge, is that DC is a pretty small jurisdiction. So again, it's not as difficult as in some places to do the groundwork to build these kind of partnerships and collaborations, because we're just we're just situated much closer. But I think to that end, we still try to very much model and kind of practice what we preach in the way that we carry out our work. So to Nestor's point, community engagement and partnership building and collaboration are real kind of foundational pieces that we make sure that we build into everything that we do. So just like you heard about with the harm reduction vending machines, like we wrote into the RFA, you have to have at least this number of kind of community engagement touch points, because we understand that that's how this kind of stuff moves, and that's how you build these sorts of movements. We also kind of have changed the way that we did our work a little bit, as Stacy spoke to, and we are really thoughtful about how we can reduce as many barriers as possible and make it as easy as possible for folks to work with us. So another example of that is with our kind of micro grantees. in DC Engage, we made that RFA process really, really, really simple. It was like 1 page of a couple of short answer questions, because we knew that we were looking to target folks that were in coalitions and not, you know, in these really concrete and really developed agencies, and that they wouldn't be able to respond to something, you know, more comprehensive than that. So I think really that focus on partnership and that focus on trying to make it easy to work with us and reducing barriers is another big way that we get at the collaboration and partnership pieces.
But to even go a little bit further, when we look at our HCV peers, for example, we used our funding from the CDC for hepatitis work, and then we reached out to some of our providers who'd already expressed interest in having hepatitis screening at their location. We paid for them to get their peers. They, in most situations, they identified who their peers were, and then we paid for them. We actually cover their salaries. So there are lots of ways that we partner with our providers, and it's not always just through grant funding. But you know, so those are a couple ways that we do it.
Do other folks have questions or comments?
Hi, my name is Sarah. I'm from Colorado. I just had a quick question about funding. Are your syringe machines, are those funded long-term, or is that a pilot program right now?
Well, currently we are actually designing a pilot, we know that the funding stream that we're going to use allows us for at least to run it for about 3 years. What we are hopeful is that if we can demonstrate access and utilization and that they are impactful, then we certainly would have to look for other opportunities and funding streams to be able to not only maintain, but also to actually expand upon them.
Thank you so much. I really appreciate that. And congratulations on all of your work.
And Sarah, if I could add, the machines are not just going to dispense syringes. We're gonna allow for syringe exchange. And we're also gonna dispense information. We're also gonna encourage our participants to link up into more comprehensive services. We're gonna do messaging through the machine. So it's not just simply a syringe exchange machine. And we were very careful not to market it as such. That's why we call it a harm reduction vending machine, because we plan to have a broader view on the services that we provide via the machines. So thank you for your question.
Definitely. And also, will those have works inside of them or just points and like information?
The machines should actually have several products. Some of the discussion that we presented was essentially that through community engagement, we expect that the funded providers will actually work with consumers to basically ascertain the initial mix of products that we might have there. As it was described, we definitely see some level around like personal wellness products. So it could be a range of anywhere from socks to hygiene kits to feminine kits, feminine products and such. At the medical level or clinical level, we're going to entertain opportunities to engage and connect people, link people to care and treatment, to other medical services, perhaps HIV testing or hepatitis C testing. And then on the harm reduction level, for sure, we would have Narcan available in those machines, as well as some other harm reduction products that the harm reduction providers, the needle exchange providers, are able to purchase with their own funds. So that's essentially how we would lay that out, because as probably everyone knows here, we are not allowed to use federal funds for the purchase of works or other such products. But if a syringe service provider is managing this, then definitely they would be able to load them with the right products for their clientele. And I'll get ahead of perhaps another question. This is a question that I faced in other presentations before, which is actually the Narcan distribution. So Narcan distribution, of course, is basically regulated state by state. In the case of DC, we need a standing order. So because we're actually doing a sub-grant type vehicle to be able to run this program, so a community service provider will actually run it, then our doctor, our CMO would be the one that would be issuing the standing order to that provider, so that then the distribution of Narcan would actually be within the legislature and what the law requires for DC. I know that that's definitely a question for other states where they might or might not have the same flexibility. So I recognize that, and that's why I wanted to put it out there. So if anyone is reading the comments, there is actually some very exciting information from Oklahoma. I'd encourage everyone to also keep an eye on the chat. And we're still open for some questions. Yep, thank you. So there are some good comments here. Folks are excited about our program. I'm glad that this is helpful. Kate, I'm not sure if
Yeah, I was just gonna, I wanted to make sure that anyone who had anything to say still had the opportunity. But does anyone from your team have anything to add or anything you want to talk about before we wrap up?
The only thing I was going to say that if anyone still has questions or wants any more details, you can reach out to any one of us and we'd be happy to dialogue and chat with folks along the way.
Yeah, and the only thing I can add is some of the things that we've actually put together. They're not always homegrown. The vending machines is something that we actually look for technical assistance from the other providers who have actually already implemented some of this. The only thing is that we added the DC flavor to it. So we're open to basically provide any supports, discussion, whatever questions you might have. If you want to dive into a particular program, then we can do so as well.
And thanks for putting in your email addresses into the chat box. And if you, for whatever reason, lose those or anything like that, please feel free to reach out to me and I'm happy to connect you all. Anything else before we move on? We have time, so I don't want to, throw us ahead. Okay. Well, thank you so much again for such a great presentation. It does seem like it really resonated with everyone and hopefully is inspiring folks as they move forward in their work. And definitely, if you wanted to, Nestor or I think Sade, you might have had the presentation, but if you want to send out the slides or you want me to send out the slides after, if you think you could pull those together, I'd be happy to send those out to this whole group. But we're nearing the end of our day and looks like we could probably end a little bit early, which I think is just fine for a 4-hour meeting. But I won't press us forward, but I do want to just leave time for I have a few wrap-up items that I want to share, but I did want to leave time if anyone wanted to share some inspiration coming out of today or just some action items moving forward or something that they're going to be taking out of today to their work. So I just wanted to leave room for folks to come off mute and share that with the team before we wrap up for today. I don't know, I hear a little bit background, but I wasn't sure if somebody was trying to talk. Well, if anyone wants to share in the chat box as we wrap up, again, any action items that you're coming out of today with, definitely would love to share that with everyone. The only other things that I wanted to say was another thank you for everyone who presented, and also everyone who helped plan for it. For today, I really appreciate all of your help, and I just wanted to say thank you. The other thing, sorry, I have too many screens going. Thanks, Emily. Definitely a lot of great information and ideas discussed today. Oh yes, okay. So I wanted to just remind everyone of the technical assistance request form on our website. We are hoping to continue to work with Safe States and HMA for them to help with technical assistance in the future. But for now, if you have anything you're struggling with the shared risk and protective factors approach, or just want to be connected maybe with other people who are working on the same issues or who presented today, please feel free to fill out that technical assistance form. I'm just going to drop the link to the website in the chat before we're done. 1 second. And then the other thing is to please continue to be in touch with me if you have resources that you want to share out, or if you're looking for particular resources or opportunities through this group. I'm always open to feedback, so I'd love to hear it. And if you'd like to present on an upcoming webinar, the next one will be in August, so I'll send out information about that. And as always, just if you have any questions, don't hesitate to reach out. We're going to be sending out an evaluation about today in the next few days. So please do fill that out so we can see what you all thought. But if no one has anything to add, I'm going to stop sharing my screen and wrap up. So thanks all for coming.
Thanks, everybody. Have a wonderful day.
Thank you. You too.